Think we'll get started. Good evening, everyone. For those of you who don't know me, my name is Jeannie Lee. I am the current president of the San Diego and Imperial County chapters of the American College of Surgeons. Normally, we usually have an actual dinner get together in the spring, and unfortunately, because of COVID, we're still not able to do that. I'm hoping by next year we'll be in a very different scenario, but for right now, this is how we have to meet. I want to thank everyone for joining. I know that some of you probably didn't get this notice until last minute, but again, I want to thank you for taking your evening to spend some time with us. Right now, I want to introduce Dr. Doucette. He is the division chief of the Division of Trauma, Surgical Critical Care, Burns, and Acute Care Surgery at UCSD, and he's here to talk to us about local and state advocacy efforts that are going on.
Thanks, Jeannie, and thanks for having me. So I'm one of the two governors of the chapter, and one of the things that governors do is advocacy. And so I'm just going to show you a few things on the state side. I think our guest speakers tonight will probably talk more about the federal side. And so just some of the updates since February of some of the state advocacy issues in Sacramento, especially. So as you know, there's a state and a federal legislative cycle, and they kind of mirror each other, and some of the topics bounce back and forth from Congress to Sacramento. And some of the hot issues right now are pre-authorization, which is something that physicians are forced to do, which largely seems like a waste of time to us most of the time. Potential cuts to Medicare and Medi-Cal, both at the state and federal level, and the ongoing saga of Medicaid expansion. Those are three topics, but certainly not all of them. And so we'll talk a bit about what's going on at Sacramento and a few things I want to focus on just in the next couple of minutes. Some of the expected bills that are coming out. One is on pre-authorization, which we've been watching. Not sure what's going to happen to this one. Stop the bleed. We do have some exciting news there. And then something interesting about pandemic bonuses for healthcare workers. So far, Sacramento has produced over 1,500 bills in the Assembly and 800 bills in the Senate, and about 3,000 bills are usually produced in an annual legislative session. There is no way all these bills will come out. Most of them are going to die a fairly ignoble death in an appropriations committee or in a night of long knives that's coming up. But some more interesting ones we'll discuss. What this one, AB4, is a bill that would basically extend Medi-Cal, which is the California version of Medicare, to all individuals who are income eligible, and regardless of their age and immigration status. So basically, this would invoke a form of universal health care across the whole state for patients who met the income requirements. It did pass in the House. It's now sitting in the Senate. It seemed unlikely that Governor Newsom would sign this, even if it did pass the Senate. However, a few weeks ago, Governor Newsom proposed that Medicaid type benefits would be allowed for all low-income adults over the age of 60, and that would extend coverage to about 89,000 people, mostly undocumented seniors. Would cost the state about $1 billion a year. So some form of this may come out. I think AB4 was designed to put pressure on the governor to invoke some kind of coverage for undocumented seniors, and I think that's probably what's going to happen, but more to follow on that one. Another bill that came out, initially this looked pretty innocuous, Senate Bill 806 by Roth. It was supposed to put more public representation on the medical board. What actually happened just last week was the bill came out with a sudden amendment for the vote without really being vetted much in committee, and it changed rather substantially. And now it's stated that the 50% license fee for all physicians and surgeons licenses would change the medical board's composition so that the majority of the board's composition would be members of the public and not physicians. It would grant the medical board the opportunity for cost recovery to use as leverage in any enforcement cases that it wants to use, and it would create an enforcement monitor. And this is done in reaction to a perception that the state medical board is somewhat lax because it only prosecutes at about 2/3 the rate that other state medical boards, and therefore there's a feeling that somehow they're not getting enough doctors' licenses away. So the CMA stepped in, and there was some negotiation. So the bill as it currently stands, the fee increase would only be 10%. There would be a slight physician majority on the medical board. This bill is still pending a Senate vote. It's not really clear what's going to happen to it, but it probably will go through in some form. So it will probably put some more teeth in the medical board, but also at the cost of a higher license fee for physicians. This bill from Dr. Pan is still kicking around. It's a pre-authorization bill. It's a fairly complex bill that basically would allow physicians, once they were vetted by the insurance company, to have essentially automatic pre-authorization for a 2-year period, and then have review. And this might be good, particularly for those physicians who do have to do a lot of pre-authorization. So the only problem with this bill is that it's fairly esoteric and probably doesn't have a lot of appeal to a lot of the members. So whether or not this would get through the Assembly is a good question. It's sitting in the Assembly Appropriations Committee, where it may die, or it may be passed, or it may be kicked into the next year, but it's not screaming through the House by any means. An exciting development is the Stop the Bleed bill. We've been trying for years to get a bill for Stop the Bleed through the Assembly, and they often go some far, but usually run out of time. The bill doesn't seem to have a lot of friends in the Assembly, but luckily we had success with the Senate side. And so Ben Hueso brought this bill in, 687, which is basically places Stop the Bleed kits with AED kits, and buildings larger than 200 people. The bill has passed through the Senate and has been sent to the Assembly. And so it does have a chance of being passed this year. And I want to thank Dr. Leppert for her efforts in pushing this bill along with Senator Hueso. This is the farthest we've got so far, and hopefully the bill has a chance of getting through this year, and might see some improvement in our Stop the Bleed response. A strange bill that is being kicked around is AB 650, which is the Healthcare Workers Recognition and Retention Act. And basically, this would force qualified employers, which is basically large hospitals and large medical organizations, to have to pay healthcare workers up to $10,000 in quarterly payments over 4 quarters as a response to what happened during the pandemic, hardships and whatnot. This is sponsored by SEIU, which of course is a large public labor union, and it's actually made it through 3 readings in the House, so it's not dead. Yeah, I don't know how it's going to actually work, because just about every hospital in California will be able to declare hardship, and that they don't have the money to pay for it. So it may be largely symbolic, but it's an interesting bill that we might see come out. Just a few things to tell you about advocacy and being a member of the college. You have 2 great tools to motivate your elected officials. One is Surgeon's Voice, and that basically allows you very quickly and easily to send messages to your Congress people and your senators, and do it with only a few minutes. So basically you can send the message on any bill or issue that you want to, and you will get messages sometimes if you wish to participate in certain issues. The other, of course, is the PAC, which is the money side of things, which is another thing that motivates politicians, is when they see societies like the College of Surgeons investing in their campaigns. And it is important for us to put some money where our mouths are. You know, a contentious group for us is the Trial Lawyers of America. Last year, they raised about $8 million, and that represents 80% participation. The Surgeons PAC raised about $1 million, but only about 3% of surgeons actually participated. So even if you only give $10 or $20, it helps that participation rate and makes our representatives, when they talk to Congress people, that makes us a little more credible when we start saying that we would like to have our voices heard. You're either on the table or you're on the menu. I'm going to quit there and turn it back over to Dr. Lee. Thanks very much.
Thank you, Dr. Doucette, for that update. Next, I want to introduce Dr. Lippert. Dr. Lippert is a surgeon with us at UCSD. She is a director of the EGS service, the Emergency General Surgery Service, and she is going to introduce our guest speaker for the evening.
Perfect. Thank you, Dr. Lee. It is truly my pleasure to introduce Dr. Gary Timmerman. He serves as professor and chair of the surgical department at the University of South Dakota Sanford Medical School, and was recently appointed as the senior executive director of undergraduate education at the Sanford Health Enterprise. Clinically, he treats patients with cancer as well as trauma, and also serves as the medical director of the South Dakota State Trauma System. He has been active in the American College of Surgeons for quite some time and currently serves on the board of regents. In addition to this, he is the current chair of the Health Policy Advocacy Group, or HPAG. The purpose of HPAG is to identify public policy issues and concerns affecting surgeons and our patients, to prioritize them, to identify the issues that the college should focus its attention and resources on, as well as to recommend those priorities and strategies for the board of regents. HPAG is a board of regents appointed group of 20 surgeons. I am proud to serve alongside of and under the leadership of Dr. Timmerman in this capacity. As such, I have gotten to know him for his insightful consideration of complex topics, deliberate approach of alternative viewpoints, and an amazing ability to build consensus as well as temper disparate views. I am thrilled to hear his perspectives on surgical health policy advocacy tonight, and excited to have him field and engage with questions from the audience on timely issues taken on by the college, such as threats to physician payment compensation, the college's perspectives on firearm injury prevention, prior authorization, Mission Zero, and any other topics you are interested in for a question and answer session, which will follow his prepared remarks. We may even be lucky enough to get some glimpses into his other interests, including rare automobiles and large game sportsmanship. It is with great pleasure that I introduce my friend and colleague, Dr. Timmerman.
Dr. Timmerman, I think you're muted.
Amy, that's amazing. Much more than I expected. And I kept wondering, who's this guy? Jeez. But no, thank you. It's very humbling. And if it's okay, I'm going to go ahead and see if I can share my screen and pull up my presentation. And let's see how we do here. And as I mentioned, good evening, welcome, and hopefully to a happier return to summer, and soon maybe a return more toward normal. I would like to first take this opportunity to thank the San Diego chapter of the ACS, Drs. Lee and Doucette, and also my dear friend and colleague, Amy Liepert, for the opportunity to advocate for advocacy on behalf of surgery, on behalf of the ACS, and of course, on behalf of your surgical patients. I would much rather be with you in person, but times being what they are, I remain honored to attend virtually and most certainly with you in spirit. So why advocacy? Why me? Why now? This is going to be a bit of a primer for many of you, and many of you, as you can tell from Dr. Doucette and also Dr. Liepert's expertise, are well advanced into the world of surgical advocacy. And yet there may be some on the phone that I'm rather on the call here that may say, you know what, I don't know enough about it, or how can I get more involved? Or, you know, is there opportunity for me to get involved? So before I go into details, I need to at least disclose to you that I have no financial disclosures to speak of. I make no money talking about the money of medicine. However, I do need to congratulate and thank the following individuals, including the College of Surgeons. Recently, this group before you here, we all served together and wrote a chapter on advocacy that is now included in what's called the Gold Book, put out by the American College of Surgeons. And as you can see, it includes your expert of the field there, Dr. Liepert, and then Dr. Warshaw, Dr. Bailey, Dr. Frankel Pelka, and many of you know Christian Seljan, who's the Director of Advocacy. So what I need to kind of let you know about is, what's a guy from South Dakota talking about advocacy, and how can this guy have anything to do with what goes on with California medicine or with New York medicine, those sorts of things? And I thought the same thing. What I thought I'd start out with is a little bit of a story about how we developed our South Dakota state trauma system. And back in 2000, the year 2000, South Dakota had the highest mortality rate in trauma in the entire upper Midwest. I was also embarrassed that South Dakota was the last state in the entire Midwest that had gone on to develop a state trauma system. Yet tourism is our #2 industry after agriculture for the state of South Dakota. So South Dakota is a large state. We're about 425 miles east to west and about 250 miles north to south. The largest city is located in the right lower part of the state. You can see Sioux Falls there. And you need to know that the state has really only 2 state trauma systems, both of them located in Sioux Falls, South Dakota. Well, South Dakota has, as you may or may not know, Mount Rushmore. It's making some news again as we're being told we're not going to be allowed to have fireworks on the 4th of July over Mount Rushmore. More to come on that. In addition to Mount Rushmore, which is in the western part of the state, up in the northwest part of the state is what's known as the Sturgis Rally. Now, this is an interesting occurrence in that there are normally about 8,000 people that live in the community of Sturgis, South Dakota. And about 5 years ago, on the 75th anniversary of the Sturgis Rally, there were 750,000 motorcyclists that came into that community in just 10 days. Oh, and by the way, we have no helmet laws in South Dakota. If you go a little bit east along the interstate, there's the infamous Corn Palace, in which, yes, indeed, this is a auditorium that is surrounded by murals on its walls made up of corn and corn seed, and it reminds me that I am indeed living in South Dakota. And finally, every fall, citizens from across the United States and the world converge on South Dakota for the largest pheasant hunt that occurs for about 2.5 months, where we kill our state bird. Well, in early 2000, there were minimal cell towers west of the Missouri River. And I happened to be in charge of a patient that was being transferred to me from western South Dakota who had been involved in a motor vehicle crash. Now, this was a tourist making her way across the state to the Black Hills to see Mount Rushmore. And at the scene, the paramedics told me that the daughter, who was actually okay, had called 911 and actually got an operator in New York. Furthermore, more commonly, if you were to call 911 back in the year 2000, you would actually get dead air. The Committee on Trauma around 2000, 2001 had done a recent survey of my level 2 trauma center and cited me for the lack of a state trauma system and called it a deficit, and a dangerous deficit at that. Yet, they also understood that this was a political issue in that there are 2 major healthcare networks, both compete against each other, both have level 2 trauma systems. And what a surprise, they both exist in the southeast part of our state in Sioux Falls. Well, I still thought this was insane. So I actually took it upon myself and I went to the competing level 2 trauma system across town. And I told them that we had to identify the greater good, which was care for the trauma patient across the state. And without telling the hospital systems, I went about my way, letting other surgeons know we were going to work on getting a statewide trauma system. I truly believe that the patient or the citizen from New York deserved the same quality care for trauma in South Dakota that they would have received in New York. Well, around wintertime, about the year 2001, I was out west in Rapid City near Mount Rushmore and snowed in with a blizzard during the state boys high school basketball tournament. And it so happened our state governor, who is today our state senator, was there eating breakfast, actually there to watch his son play basketball. Well, as it turned out, he was stranded, I was stranded. I went over and I introduced myself and I told him that being stranded in a snow blizzard is part of the problems we have in South Dakota for access for trauma to our state, and that we have no statewide system to address that. The blizzard actually highlighted my points. I then went back after the blizzard and visited with my colleagues in the trauma and healthcare system and finally got them to agree. And we assembled a team to proceed with drafting legislation. Remarkably, in March of that year, the governor actually called me and told me that he had included a state trauma system into his upcoming budget proposal for our South Dakota legislators. Well, our group went on to be asked to testify at the House and Senate subcommittees, and this legislation ultimately passed overwhelmingly by both chambers. It was signed by our governor into codified law, are you ready for this, in 2008. Remember I said I started this in 2001, and I was fortunate that this governor was a two-term governor, that he was still around to get it done. Rules and regs were drafted in 2009, and we implemented the expectations to all the South Dakota hospitals, including critical access hospitals. And in order to get them to buy in, I actually made them all trauma centers with requirements of what would be necessary of a trauma center. Well, nearly 15 years later, South Dakota trauma mortality rates are actually below the national trauma rates. And we have remarkable survival rates, even with great distances in which we get people to a trauma center, if you will, even though it's a critical access hospital. Not all unlike MASH centers in times of war. So, there is always the perception. The perception is that there is something wrong with doctors actively participating in advocacy. I've heard comments like, I tried it once and I got nowhere. It's a waste of my time. Don't we pay people to do this for me? Listen, I'm just one doctor. Yeah, it won't make any difference. Hey, politics are dirty. It's unprofessional. I don't trust politicians. And they only want my money with no results. Well, surgeons see things and a little bit differently. We see things that are broken and we want to fix them with prompt results and outcomes. Why, even when we're all doing medical resident interviews, I always smile when I read their personal statements and they detail how they're so attracted to surgery because of the immediate outcomes of an operation versus the other specialties where you have to wait to see if it works. I always say to myself, wait till they take care of an enteric fistula. Well, an example of a surgical project might be surgical research, in which you develop a hypothesis, identify a problem, or you make an observation. Then you organize a study. The ideal, of course, is prospective randomized studies. We then collate data and we analyze it. We construct an article or a presentation, and then we share the results. The bottom line is we get it done promptly. Well, in the world of advocacy, it's a little different. You have to develop a policy or a cause or a viewpoint, like stop the bleed or a state trauma system. Then you have to establish or create relationships or a team of like-minded individuals or agencies. And oftentimes, the team players know nothing about the issue, such as politicians or their 20-year-old assistants. Then we align or persuade the other individuals on the issues, many of which are against you, irrespective of the facts that you know to be true, which is very demeaning to surgeons. And then if you're fortunate, you might be asked to present to a committee or a legislator or a regulator or a governing entity, which, by the way, probably doesn't know much about what you're talking about anyway. And then you have to lobby, often, again and again, on behalf of your issue, which means oftentimes more time away from your practice, one more trip to the Capitol. And then you pray the legislators and then the executive branch of government will agree with you. Commonly, as I said, this takes years to complete. And the surgeon says, where's the logic or science in that? Well, this is where I come to the definition of surgical advocacy. Listen closely. It's the action by a physician to promote those social, economic, educational, and political changes that ameliorate the suffering and threats to human health and the well-being that he or she identifies through his or her professional work and expertise. Listen, we advocate for our patients every day. You've already heard, you've got bills for prior authorization. That's advocacy. The continuation of care and sign-outs by the residents. That's advocacy for your patient. Home health, wound clinics, medical devices. New technology, is it safe? Do I know how to do it? EMR accuracy, oh my God, I could go on and on about that. And then ultimately, the patient experience. Therefore, it is my belief, and should be yours, that it's our professional responsibility to advocate at a minimum for our patients. So as we go on, there are a few terms we need to at least identify. First, of course, is policy. It's a course or a principle that can be medically related, such as diabetes, access to care, malpractice, fiscal or regulatory things like the ACA. Then there's what we call the process, which is the series of actions or steps necessary to advance your policy, followed by politics. This is where the fun begins and often ends to complete the process and advance the policy. Well, there are, of course, different types of advocacy. The first might be issue or topic-based advocacy. Now, the focus here is on the science of medicine and or its clinical application. Often, this type of advocacy is focused on specific diseases or conditions that protects our patients. We often assign them as grassroots or local advocacy. Historically, it involves personal relationships with local legislators or community leaders. It's probably the most common application of advocacy nationwide. However, the great thing about it is it can oftentimes grow into something bigger when appropriate, which leads us to the next phase, which is, as you've already heard from Dr. Doucette, state advocacy. This is very much like grassroots advocacy with the same personal relationships, but now with often state leaders. Common themes, of course, include injury prevention, like what I did with the state trauma system, or seatbelt or helmet laws, or even scope of practice. We've all heard about that. And then from state advocacy, you might push into federal or national advocacy, which is always the most visible. Again, you have to foster relationships with legislators. I always say these people, you got to remind them that they represent you and you are now their constituents. And the best part about being a physician is that Congress is always looking for medical input and knowledge, particularly how it affects their home state and their home state constituents. Personally, it's the most complicated, difficult, least gratifying, and usually the most unpredictable advocacy I've ever been involved with. Its issues are usually very complex. There's support and adversaries everywhere. Often the issues are related to money and also favors from others. So what types of representation are there? Well, certainly the individual themselves can be a representative. It's known that about 92% of surveyed physicians considered political involvement important, yet only 26% of them had actually been politically active on a local, state, or national level. Then there's the societal membership representations. I already heard about your CalMed. There's the ACS, there's AMA, there's your SAGES. In fact, the ACS has a division on health policy and advocacy in Washington, D.C. And the great part about there is they represent surgeons on our behalf, knowing that the issues are usually complicated, time-consuming, and require a lot of expense to get things through. And then the final type of representation can be your political party, such as Republican, Democrat, or Independent. Now, this advocacy is usually based on the party's platform. And you have to also understand that when you dip your toe into that water, you're going to be facing issues about 50-50, where 50% of the nation disagree with you, whether you like it or not, or whether it's right or wrong. So, when does one decide to advocate? How do you choose your battles? Do you choose a specific issue or a policy? How about self-employed versus employed physicians? Why not pick academic versus non-academic issues? Then there's healthcare issues like access to care or cancer, or even economic issues like malpractice, reimbursement, E&M codes. Often these topics are tackled by your medical societies, such as the ACS or the AMA. many of their topics don't necessarily directly affect you. However, if you're a member of that group, you quote, gotta support the home team, end quote. Then what about societal issues like the ACA, like abortion, like gun violence? Well, let's talk about that. One recent impossible, politically charged and divisive topic was gun ownership versus gun control. The narrative for each side is that for one group of folks, guns equal personal freedom and safety. And for another group of folks, guns limit my personal freedom and represent violence. Knowing that firearm injuries directly affect surgeons and their patients, the American College of Surgeons deliberated its role in the debate on firearm injury. The advocacy options that were available to us in the college included A, defend and support the Second Amendment rights for gun owners. B, promote increased gun control measures. C, remain quiet, don't get involved, tasted. Or D, seek a consensus or a compromise on this controversial issue. Well, the college chose to search for a consensus based on the principle all surgeons could accept, which was we need to reduce firearm injury and death. The ACS leadership conducted 3 separate surveys of its membership and realized that the fellows were split nearly 50-50 on the topic. Gun control surgeon advocates assembled a list of action steps suitable for gun violence reduction. A firearm strategic task force group was then formed, comprised of firearm owning surgeons, and they deliberated on firearm related injuries and prevention. The conclusions of the FAST work group and the ACS leadership initiatives resulted in open and constructive dialogue for increased public safety, safer firearm storage with enhanced personal responsibility for gun ownership, greater awareness and enforcement of existing gun laws and regulations, and the promotion of innovative and greater weapon safety technology. The collective results fostered a consensus recommendation regarding strategies and tactics to increase firearm safety, reduce the probability of mass shootings, reduce firearm-associated violence, address mental health factors, and encourage federally funded firearm injury research, all while preserving the right to own and use a firearm. In fact, both sides felt like they won. So, how do I advocate? Well, understand the process as best as possible. I have to tell you that whatever you do, if you like hot dogs, don't go to the meat locker and watch it being made. In other words, you never want to be there watching sausage made. A lot of things get done that might be very disgusting to you, can really turn you off to politics. It appears daunting and complicated with many, many roadblocks to curb your enthusiasm. So the key words here are determination and patience to see it through. Hey, surgeons, they inherently possess the first, but commonly lack the second. Many individuals and agencies can help, particularly with federal agencies like our Division of Advocacy and Health in Washington, D.C., or even HPAG that I serve on. Surgeon's Voice was mentioned by Dr. Doucette, as well as Surgeon's PAC. Many call it the, quote, dirty laundry of Washington, end quote. Wouldn't you think that certainly a noble and just cause or policy should be enough to have it pass? Unfortunately, to get in front of those legislators that make it happen can, quote, come with a price, unquote. There's somewhat of an unspoken, I call it, admission price to meet with them. It makes me angry as well, yet perhaps look at it this way. Are not museums, art galleries, national parks, property owned by all of us Americans? Yet we willingly pay an admission or entrance fee to visit them. In politics, the admission fee is $200. I'll repeat it. It's $200. This amount will then register you and your contribution to that individual. It's discoverable by both Democrats and Republicans, and believe me, they know to who and how much you've given to each of those candidates even before you come to see them. Our PAC serves as one source of the admission fee on your behalf to ensure access to our legislative process and to further advocate for what I would call that noble issue or cause. So in conclusion, really, what are the levels of advocacy? Well, Amy listed it quite nicely. There's what they call, or she calls, engaged, in which certainly the full active engaged would be making legislative comments, making calls, contributing to the PAC, making personal contacts with the legislators, holding fundraisers, engaging others to act. Partial active, probably making, again, limited contacts, but will, do emails, make calls. You'll contribute to the PAC. You're typically aware of the issues, and you read summarized information. Then there's the passive physicians. They send automated letters and emails, and they may or may not attend events. Then there's absent individuals that are aware of advocacy and that it's happening, but they just choose not to participate. And then unfortunately, the disengaged, those doctors that purposely avoid or even criticize the efforts of those trying to get things done. So where is politics in 2021? Well, at one time, politics was an art of reaching a compromise suitable to both sides of an issue or a concern. Skilled legislators attempted to achieve their party's or a constituent's goal through debate, negotiation, and ultimately consensus. The endpoint of the deliberations would be an acceptable compromise in which both sides left the room as winners, not that one winner took all. Further, goals achieved through the negotiations often served as starting points for future opportunities or next steps. The final outcome left no blood on the floor and left mutual respect between the participants. John F. Kennedy said, "Compromise need not mean cowardice." This concept, particularly in Washington, has been lost of late. Yet I see an opportunity. Surgeons inherently represent professionalism, compassion, and possess the ability to arrive at solutions best for their constituents, namely their patients. We as surgeon advocates can particularly impart these qualities back to the legislators. Wow, what a thought. In a nutshell, it's a marathon. Expect opposition. Base credibility on values, not personal rewards. Use stories. It personalizes it. You have to build relationships and find allies. Oftentimes they're on the other side of the aisle, but be realistic. Hey, one final story. In the 1980s, where I trained at Rush Presbyterian in Chicago, they would send their general surgery residents to National Children's Hospital in Washington, D.C. to gain additional pediatric surgical training. While I was there, my wife Gina reached out to her cousin Kimberly, also originally from South Dakota, for companionship while I, of course, slaved away at work. Kimberly's husband, John, worked for our South Dakota Senator, Jim Abner, as his legislative assistant back in, I think it was like 1982. Well, John taught me much about the Washington political process, and we became fast friends. 5 years later, he reached out to me to help him run for the U.S. House of Representatives in South Dakota. Well, he won that election, he kept winning, and he moved up the ladder. And today you know him as U.S. Senator John Thune, the second highest ranking senator of his political party. We still meet nearly weekly for dinner, and I usually enlighten him the best I can on issues of medicine and patient care. In conclusion, you never know when an opportunity will bite you in the butt, but if the door suddenly opens, it's still up to you to walk through it. Thank you. It's been an honor and privilege for me to visit with you about this. Certainly, many of you know most about this, but if I can answer any other questions specific to Washington, if I can, I'd be honored to do that. certainly entertain questions, and thank you.
Thank you very much, Dr. Timmerman, for that great presentation. I have one question. I think Amy might have some more, but my question is, a lot of us are novices at this. We have not been at this nearly as long as you have, or have never done advocacy at all. If there's one thing that you say that we should do in terms of, for those of us who are very much beginners, what's the one thing you would recommend?
Well, it really depends on what you want to get done or where you want to start. And it's always easiest to start at, they always say, the grassroots level. And, that's where I started. Just by circumstance and happen chance that my individual happened to climb the ladder. And then that governor that I was talking about, he's our other U.S. Senator, Mike Rounds, rather. And then our U.S. Congressman is Dusty Johnson, who's a pheasant hunting buddy of mine. So, I mean, you fall into those, but you start the relationships early. You start with them even before they necessarily run for anything in the state. And so if there's somebody that you think has an opportunity to go forward, or if they think they speak for an issue that you want, you let them know. But then there's always kind of a tit for tat. There's always the idea that, hey, I'm going to run for House one day, or I'm going to run for this. Would you support me? And you know what? If you get on board with somebody really, really early, those legislators never forget that. And you're on their side through thick and thin if you're there. You also then have to remember that, at least in my world, they're my friend first and they're my politician second. And I've kept that always in my heart so that I don't judge them on every vote. I never expect them to vote 100% the way I want them to vote. They have to do things. I recognize, and remember I said it's making sausage. They have to make deals. They have to do whatever it takes to get something legislation passed, or they know if they do this, then they can get that done. It's very complex, especially on the national level. On the state level, it's usually a little more simpler, but in even your local Congress people or your local representatives, it starts with making relationships, and it starts with taking the topic you want to them. And then don't be afraid to listen to the other side. You have to learn. Probably the one thing I've matured the most with in politics is listening to the side of my enemies that are against me, or against what I want to get done for the college, because I have to figure out a way to somehow find a sliver of opportunity there. And we have that. What's great about our HPAG and what's great about the PAC board is, believe me, there's Republican and Democrats, strong Republican and Democrats on both sides. And we're best friends in that room. You kind of drop the politics and you go for the topic. And the topic is patient care or patient health. That's what we serve. And then I try to leave national politics that are strictly R&D out of it. And I think the college tries to do that too. So, I mean, that's a global thing, but if you're going to do anything, it's probably making relationships and being sincere and being there for them. And then, not necessarily being so horribly hard on them if they voted not the way you wanted. Because maybe the next time they'll vote for 3 things you want. I've learned that the hard way.
There is a question from the audience. I've done public policy advocacy for Aspen and Ole Foundation for years and found the most effective advocates are the patients. How does the college involve patients in the process?
Oh, wow. Isn't that great? You know what? Hopefully more. We have tended not to use patients for fear of exploitation, maybe. I don't know. And I think that feeling or flavor is changing. And Dr. Liepert will agree with you on our phone call that we had with health policy last night. They talked about personal stories and they talked about, getting patients involved, and do we finally bring the patient into this on a national or federal level? And I think the consensus, Amy, correct me if I'm wrong, is yes, we're going to do it. And I think the fear has always been the perception that we might be exploiting a patient. And I think we have to get over that and really turn to the folks that we support and let the people that we support us more. So I think that's a great question. Amy, any comment on that? Is that what you heard as well?
Yeah, I agree. I think just globally with advocacy in any industry or realm, there's been a better use of patients or the individual in the community as the storyteller, and so I think we do have opportunity for that. I do think for those of you who are interested in becoming engaged in a topic or an issue, we still as surgeons serve that role in a great way, and to have the perspective of relying on a lobbyist, they can't do that in the same way. And so I think we need to both use or encourage the use of patient stories and patients themselves, but also use our own stories, because in many ways we're the ones being affected by some of these things and affected by the access of care issues. And we can use those stories as well for our legislators.
Other questions?
Oh, there's another one. I think there are so many aspects of advocacy for the college. How does the ACS prioritize the most important topics in advocacy?
Yeah, great question. I think the health, okay, so the HPAG, Health Policy and Advocacy Group, meets, well, historically we would meet like 4 or 5 times a year, and every meeting we would have, we would look at our list of priorities and then categorize them as to what's the most pressing based on maybe what the governor's survey might say, or what the fellows surveys may say, or what the biggest complaint lodged to Washington might be. And 25 years ago, it was all about malpractice and the SGR. And then now it's, of course, about Medicare cuts, and it's about pre-authorization. And believe me, all of those things have been on that scale of 1 to, are you ready? 40, maybe 45 different pressing issues that the college has to try to prioritize. And because each one of them bubble to the surface at different times, that's why we meet 4 times a year, to be able to look at that and say, number 12 is now number 2. We better talk about that. And number 2 really isn't on the screen anymore. We got to move it down. It's almost like the top music. What's the number 1 hit in America? And they go up and down the scale. It's literally that way. And I can remember when, are you ready for this? Telemedicine wasn't even in the top 20. And that was 2 years ago. And along comes COVID. And telemedicine jumped to like number 4 because of the means in which we had to follow our patients through teleservices, telemedicine, tele-ER, tele-everything. And it's a great example of where something was not even considered, hey, telemedicine, that's rural South Dakota. That doesn't affect us here in California. That doesn't affect us in New York. That's way down on the list. And all of a sudden, and I remember saying, well, telemedicine might be kind of important for South Dakota, but I recognize that's not as much as what other things might be for malpractice or different issues of scope of practice. So by golly, we'll put that one aside. When then all of a sudden, it didn't matter if you were in California, New York, or wherever, you had to get a hold of your patient, but they couldn't come see you. You needed telemedicine. So you don't think it didn't bubble to the surface? That's how that list goes up and down all the time. And literally, we're looking at that top 40. And some, I don't know that they ever really completely fall off the list. And then there's always new ones. 10 years ago, who would have thought EMR was a big deal? 15 years ago. And now look where it's at. So again, we have to stay current with what's going on in healthcare. The employed physician, how is that versus the private practice physician? What about rural surgeons? All of those topics are there, and they get their weight based on what's coming up in legislation, just as Dr. Doucette said, hey, we got to pay attention to this bill and that bill, because this one snuck up on us. We didn't expect this one, and all of a sudden, this is going to be an issue. That's, kudos to you, Dr. Doucette, that you're following that and recognizing someone's keeping an eye on that. And that would have otherwise been, what if you wouldn't have known about it? And all of a sudden your rates went up 50% on your, and then 10 citizens are telling 4 doctors how to run their medical board of examiners. So thank you for doing that. And that's just paying attention to what's going on in the legislature. Great question. Amy, you had asked me earlier, what do I think is the #1 advocacy issue today? And we heard it last night, and it's going to be that way till December 31st, and that's Medicare cuts. And, you know, we got a reprieve last year. We got it done after the final bill was published in a effectively a dead House and Senate in an election year with a president who was outgoing, and somehow, some way, we were able to cut the proposed Medicare cuts, but it happened for 1 year. And regrettably, the cuts are back. There'll be the expected 3.75% cut that will come to us to offset the proposed increases to EMM codes, and they'll cut our conversion factor, which directly affects surgeons, by 3.75. There's what's called sequestration, which is a cut that will amount to about 2% to surgeons, and then another cut called pay as you go, which is about 4%. And then I smiled when Christian explained this to me last night, that in Washington math, instead of that equaling 8, it's more like a 9% cut. When they add those numbers, it always ends up more than you think. And so whether we like it or not, and we're going to be facing another 9% cut, and we won't now have COVID to fall back on and say, well, listen, you can't take funding away, as they say, from the military in the middle of a war. Well, they think the war is over, and so now it's good to look at taking funding away. And so we have to think of different ways to offset that. Certainly, what's happened in the last couple of years is we've made a number of coalitions in Washington with the other surgical specialties. That's going to work to our advantage. And you know, you always speak with greater authority in Washington when you have more team members on your team, and the coalitions bolster our numbers, which makes Washington kind of stand up and take notice. But it's we're not at all done with fighting those cuts, and so that will be my job and Amy's job and all of us on HPAG. And then you'll be getting, I guarantee you, as you did last year, a number of blasts, email blasts, that sorts of things, that contact through Surgeon's Voice or legislators. I'll tell you one thing about Surgeon's Voice, and a lot of people think that doesn't make a difference. It does, in that in the old days in Washington, a legislator would decide whether to vote for something or not based on how many favorable letters or non-favorable letters they get on the topic. And now, of course, it's not letters, it's emails or it's electronic messaging. And so even though you might be saying, well, this is a waste of time, I'm just sending this, you know, scripted letter to them, it doesn't matter. They're counting those. And if you took the time and effort to click the button, they're counting you as an advocate for that, or an adversary to that issue. And so you may not think you're doing anything by that, but in fact, in Washington, that's today how they make their decisions on a lot of these topics, is head counts. And I learned a long time ago, I was asked by our nurse anesthetist, well, actually by our anesthesiologist, about a scope of practice issue in South Dakota, where the nurse anesthetist wanted freedom of practice without, this, not the nurse anesthetist, yeah, the nurse anesthetist wanted freedom of practice, CRNAs, and the anesthesiologist didn't want them to have that. And so they asked me as a general surgeon to come lobby against the CRNAs having independent practice. And this is probably back like in 1996. I went there, I was a rural surgeon, and I went there, and I had no anesthesiologist, so it was me, the MD, that was writing and signing off for all the CRNAs. But I still thought they should be under my purview or my direction. So I testified at a House committee meeting on it. And there were maybe 6 anesthesiologists and me, so 7 of us. And I got done testifying and I thought, there, I told them, you know, now they know, now they're smart. I educated them. I told them it's not safe. They need an MD to co-sign. They shouldn't have interpret. I've got this. And as I walked out of the chamber, the hall was packed with CRNAs. And as I left, the CRNAs poured into that room. How do you think the vote went? It went the way of the CRNA. And it was like, good, you know, but I told them the truth. But then I learned it isn't always what I tell them. It's a lot of times the pressure they feel when they go back, because those 150 CRNAs help get them reelected more so than maybe the 6 of us doctors that would get them. So it's a little lesson I learned along the way. Other questions?
So Dr. Timmerman, I have one for you, just to kind of sum up a number of the things we talked about as far as advocacy goes and the importance of grassroots advocacy for each of us to individually reach out with electronic communications, with the college working on our behalf, with professional lobbyists. And you talked a little bit in your presentation about the PAC. And the PAC seems to make a lot of surgeons really uncomfortable, the idea of giving money. I was hoping you could give us a bit of an overview of, again, of the importance of that, how the college actually decides to give the money to, because sometimes there's a perception they only give to Republicans, they only give to Democrats, and why it's important to give to people, even if it's different than what our personal politics and how we may vote personally in a voting booth, why it's important that we support those legislators for the House of Surgery.
Remember when I said, Amy, that a lot of times you win battles when you have both sides of the aisle on your team? So if you are seen as only a one-sided group, you know, it's really, I think, hard to get things done. And you have to remember that your constituents, your patients are Republican and Democrat, your doctors are Republican and Democrat. And so, as I had mentioned, I've had the good fortune, I've been on the HPAG and I've also been on the PAC board. And that board decides, you know, who they're going to give money to and you know, relatively how much, but the amount is not huge. But they do a vetting process. If a legislator, Republican or Democrat, comes to them, there is a form they're asked to fill out, and it's all pertinent to patient care, and it's pertinent to interests of the College of Surgeons. And some of them just choose not to fill it out because they don't necessarily want to, or they don't seem to be in line with what we think is a good thing for the college. You'd be amazed, though, how many equal Republicans and Democrats will sound virtually the same when they fill out those forms. And when we're looking at getting something passed for scope of practice, or getting something passed for patient access, or trauma care, or Mission Zero, or all of those things, it's always easier to get it through Washington if you both have Republican and Democrat buy-in. And so it is probably more coincidence than it is intention that at the end of the day, we're very close to 50% Republican and 50% Democrat who we give to. It usually favors the party in charge. So right now it's more Democrat than Republican, but when Trump was in office, it was more Republican and Democrat. And when Obama was in office, you know where I'm going. It's always a little bit one side or the other. It's usually equal representation, if you will, of percentages, both in the House and the Senate. We typically make a couple of major contributions to 2 stars that we think will really benefit our surgical patients and the causes of surgery. And I've always seen them to be 1 Republican and 1 Democrat. So those capital investitures are always equal. We never give to a presidential race. So there is never money going to one president candidate or another president candidate. And so to that end, they do a very deliberate job of looking for balance but more importantly, looking for candidates that will speak to and be willing to put their necks out for causes for surgical patients and surgeons. And that's why I have no problem giving money to them, even though I know that 50% is going to the party I don't vote for. Remember, I said it ain't about that. It's about what's good for my surgical patient. And remember, I also said in there, you got to support the home team. In this case, the ACS is the home team. You can still pick your candidate and give money individually to your Republican or Democratic person you want. There's no one says you can't do that. But when it comes to the PAC is done with the intent that it helps and gives access to those legislators that support surgical causes and surgical patients.
And would you be willing to comment on some of the college's internal review of their perception across Washington of what the college looks like to the legislative body?
Oh, well, thank you. Yeah. Well, we heard that last night too. You're timely. Yeah, that was interesting. I'm assuming you're talking about how how legislators see the college. Right. And how legislators see surgeons. And it's interesting to me that they make a delineation. The college is seen remarkably of high value to Republicans and Democrats. In fact, I think we are number one or number two most reliable organization for getting them the facts and getting them unbiased information to both Republicans and Democrats. In other words, if a legislator wants to know what does MIPS really do to doctors, they come to us now first, not the AMA. And we're seen in a more favorable light in the legislation for truthful information, truthful background, medical information, much more so than any other medical association in America, which we've earned. And I think that speaks well to your Washington staff, speaks well to those people that I mentioned, Christian, Pat, and Seljan, Christian, Pat, and Frank Helka. And then we learned last night that legislators seem to make a line though, and they seem to say, yeah, we think a lot about the ACS, but not so much about the individual surgeon. And there is the perception in Washington that we're still overpaid. There's the perception in Washington that we're still entitled and maybe not as valuable or maybe seen in a lesser light than our primary care providers. And in that, I say, hey, kudos to primary care. They really sold themselves and we didn't. We certainly have sold the PAC. We've certainly sold the ACS. And this is where I think maybe it's time to bring patients in and start telling personal stories about surgeons that are not necessarily seen as warm and fuzzy people. And that's where I think that the efforts might be more directed toward getting patients to actually share with our legislators the value of surgery and the value of surgical care. Is that your answer you're looking for, Amy?
Exactly.
Other questions?
I don't see any new questions. So unless our panelists have any other questions, I think that might be all the questions. I want to thank you, Dr. Timmerman, for spending your evening with us. I know it's a little bit later for you than it is for us, so thank you for staying up with us.
You know, it's 9 o'clock. I'm usually sound asleep by now, you know. No, I'm delighted. Thank you so much for the honor. I hope this wasn't demeaning or below what you thought. I hope that you maybe learned some tricks or at least some insights as to how we do things. So
I did, and maybe next time we can do this in person so you can actually enjoy the San Diego weather. So
God, yes. preferably in January.
Well, thank you for your time, and for all the panelists, thank you for your time, and for all the attendees, thank you for joining us this evening.
Thank you.
All right, thank you.